Here.
I think that was a yes.
Yep.
Ebony Clark,
I'm there.
Jessica Gomez,
Here.
Kirsten Isaacson, Brenda Johnson,
Here.
Bill Kramer,
Here.
John Santa.
Here.
Great, thank you. We have 7 of 8 members for quorum, and I'll connect to see if we can get Kristen connected.
Well, welcome again, everybody. Today marks the start of the Chinese New Year. Happy New Year to all of our communities and partners and colleagues who celebrate this holiday. Also, February 1st through March 1st is Black History Month. There are many community events that are taking place across the state, and we hope that everyone who has the opportunity to learn, celebrate, and honor the triumphs and struggles of African Americans and the Black community throughout the U.S. will do so. Also, I want to update you on Pat Allen. For those of you who have not heard, just about a week ago, Pat was hospitalized after a serious fall. He's now resting at home, doing well. His hospitalization was not related to COVID-19. We heard he's in good spirits, making jokes, and we wish him a full recovery. Big thanks to Kirsten Isaacson, who organized well wishes from the board. For the interim, for the time being, Chris Krautz, OHA Deputy Director, will be in charge of agency operations in close coordination with members of the Director's Office team, Don Jagger, the Chief of Staff of External Relations and Division Director, Dr. Dana Harganati, the Chief Medical Officer, and Dave Baden, the Chief Financial Officer. We are also tentatively marking our calendars for the 2022 annual Oregon Health Policy Board retreat, which will occur via Zoom on April 5th and 6th. As planning efforts resume, additional details will be shared. For now, we place holds on all the members' calendars and asking others to pencil in that date. On another update, I will be stepping down as Oregon Health Policy Board Chair and leaving the chair to the good hands of our Vice Chair, Oscar Rana. And also announced that I will be stepping down as the OHSU PSU School of Public Health sometime in the second half of 2022. And my wife and I, Lynn, will return to the San Francisco Bay Area. Just want to say it's been a real honor and pleasure, one of the greatest honors and pleasures I've had to serve as your board chair and to participate on this board. So I will step down as board chair, hand it over to Oscar, and then we'll continue to participate until we relocate to San Francisco. For today, we have a fairly flexible time frame in terms of our agenda. There's an opportunity to have an update from the OHA waiver team asking us to submit a letter of support for the upcoming application to CMS. We also have Oregon Health Authority agency updates to be shared by Rachel Banks, the director of OHA's Public Health Division. The legislative team will join us for a preview of the 2022 short legislative session, which starts today. We'll have an update for the Oregon Health Plan and Oregon Health Insurance Marketplace, and we'll conclude the meeting with public comments. So now we'd like to move on to approving the minutes from the last meeting. Is there a motion to approve the minutes?
This is Brenda, so moved.
Great. Do I hear a second?
This is Ebony, a second.
Any comments or discussion? All right. All in favor, say aye.
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 Any opposed? Any abstentions? Very good. The minutes are passed. So I will hand it over to Jeremy Vandehey to talk about the OHA 115 waiver update.
Great, thanks, Chair Bingsberg. Before I dive in, as David mentioned, Rachel will be here to talk about COVID updates that Pat would normally provide here in a few minutes. She had a time conflict, so that's why we're kind of out of order on that update. I wanted to say before I dive in here first, was able to text with Pat a little over the weekend, and I appreciate everybody reaching out and sending good thoughts. I think obviously was hard for all of us to hear, but really relieved to hear him back home very quickly and recovering, and know he's anxious to get back. And unfortunately, his wife is making sure that I think she hides his work phones and things and prevents him from doing that too quickly. So, but I know we're all continue to have him in our thoughts and appreciate the board's support. Second, wanted to say, Dr. Bainsberg, very bittersweet news. We're really excited for you and the next adventure for you and Lynn in San Francisco. It's been just incredibly wonderful working with you. I know you're not leaving yet, and I'm sure there'll be many more opportunities for kudos and well wishes. But just want to say thank you so much for your leadership over the last couple of years through CCO 2.0 procurement, through pandemic, through waiver work, and several great retreats, getting the board priorities and structure and helping us build out membership. And we're just very grateful for your leadership, and thank you so much. All right, so our next agenda item, we wanted to just have just like 2 or 3 slides here real quickly. Really the topic here is to seek a letter of support from the board. When we go to the next slide, for the 1115 Medicaid waiver. Overall timeline, just a refresher, we've been working on this now for almost a year and a half, and most recently finalized concept papers for major policy areas in November. Had a public comment period in December that closed around January 7th. We've been incorporating feedback and making changes to the final application that will be submitted hopefully in the next week to 2 weeks, heading for the first half of February, and are on track for that. Directionally aren't making significant changes to the overall policy direction. Are making some tweaks on some of the details, but the 4 main policy concepts and major asks will largely remain in the application. Once we submit the application in February, we'll go into basically negotiations, for lack of a better term, with CMS that will go probably beyond the current expiration date of our waiver, which is June, and expect that we'll get a short-term extension to be able to continue finalizing the final waiver throughout the summer and into the fall if necessary. They've committed to getting through the process this year with us. Once the waiver is approved, then we'll go into implementation, and different pieces will roll out at different times depending on sort of the lift and where they go. Would expect some things may begin to roll out as early as 2023, and some of them may hold over for the next 5-year CCO contract that won't begin until 2025. So it sort of depends on how things get finalized and timeline. But will be an implementation that is not a sort of switch just automatically being turned on, but really an implementation that will phase in throughout the course of the next 5-year waiver. Next slide. Just a reminder, we've really seen the waiver as a key goal, not the only lever, but a key lever in the agency's goal around eliminating health inequities by 2030, and are really grounded the waiver and policy concepts that help advance equity. There's four overarching categories. How the waiver helps with the state's goals around reaching universal coverage and trying to ensure every individual who's eligible for the Oregon Health Plan, and to provide more continuity of care as folks are moving in and out of life events that have them on the edges of eligibility. Secondly, around a number of flexibilities that help ensure that the health system sort of follows people through life transitions as they're moving in and out of other systems like behavioral health or public safety, but also being able to better connect with health-related services and health services that and social services that improve health that aren't medical services. So things like housing supports and better wraparound services for folks during climate change events. Third has been continuing to evolve how we pay CCOs to create a more flexible, predictable population-based payment that really drives accountability for population health down into the system. And then finally, are asking for fairly significant new federal investment to recognize and match a number of investments the legislature has made in healthcare programs in a way that would create some new flexible funding for communities to make investments in health equity. Next slide. So we've talked with you all a lot about this over the last year and a half. I really appreciated feedback and input and direction, as well as a lot of support for conceptually the high level asks of where we're headed. We'll be submitting the application here shortly, and with that, we'll be submitting letters of support from organizations that want to submit a letter of support, and would love to have a letter of support from the board to accompany the application as well. And so I think with that, I'm going to turn it back over to you, Chair Bingsberg.
David, you're muted.
We have some time for discussion. I wanted to just get temperature of the board in terms of putting forward this letter of support on behalf of the waiver initiative, and see if there's any comments or concerns regarding that letter of support. Jeremy, what will be the process of composing it and sharing it with the board?
We have a draft drafted. I can't remember. It sounds like we did not send that around the board. I think generally how we've done this in the past has been basically a vote to allow the chair to work with us on final language and sign on behalf of the board.
And then it would be then reviewed by the board?
We could certainly do that. Usually we just have the board vote to approve a letter of support, but would leave that to your discretion if you want to send it around ahead of time.
Ebony?
Yes, no, this is very exciting to continue to see, the effort. What I appreciate also seeing is not losing sight of kind of, the values and intentionality that we're wanting to bring forward, specifically to, equity and to, just the way that we're working to try to, reimagine and be more effective in the work. One question that I have, and I'm happy to also kind of provide some information offline, is thinking about the juvenile justice or, youth. And I know that when we think about kind of, what we're wanting to bring forward in terms of being able to have a level of in-reach specific to those who will be re-entering the community from incarceration, want to make sure that there's also reciprocity with youth, as we also are looking to propose this with adults. And so just want to put that out there. Jeremy, I'm happy to send an email and kind of provide some more detail, but just wanted to put that out there.
Thanks, Ebony.
John?
Yeah, I would just like to say I've been following this along, and I support where we're going. And my sense is there's some terrific stuff here as it relates to equity. And I would support the board writing a letter, and when the chair's ready, I'm happy to make a motion to do so.
Other comments? Go ahead, Jessica.
I have a question. So during the last meeting, I was asking about the, it's like a community consortium or board that was going to make decisions about sort of the equity dollars and how that relates to CCOs. And I didn't really get an answer about that. I am still really concerned that that is going to continue to increase cost and complexity.
Thanks, Jessica. So the waiver does propose creating new community investment collaboratives. These would be CCOs and other partners would come together, and this would be to invest both the dollar and direct investments of dollars that the legislature's directed CCOs to make. They've asked us to include in the waiver that 1% of of CCO's global budgets would go to community for health equity investments. So it would be that, as well as the new dollars, and recognize this would be a new infrastructure. CCOs would be partners as part of that. I think there is some mixed feelings among CCOs. I've certainly heard a couple of strong voices of not liking that approach. I've also heard others that seem fine with it. I think in particular, though, this is the idea of having these collaboratives and community voices really been a response to the regional health equity coalitions and community who testified at the last meeting and have asked us really specifically that if we're going to have dollars directed towards equity, that the community really direct where those go. And so I think we've really tried to be responsive to the community asking us to do it in this particular way. And with all that said, the waiver application is sort of a starting point with CMS. It'll be a negotiation, and we don't know yet whether we'll get those dollars. And still there will be some time to work through some of the implementation details. But like I said, we've kind of hit an impasse, I think, with a couple of the CCOs who've had some concerns because we're really trying to represent the community voices that have asked us to.
I mean, I get that, but I am concerned about just the increase in cost and complexity of doing this. I mean, we've got 1% to work with. I just see us adding layer upon layer. If you look at what we did with some of the behavioral health dollars, I mean, there's I don't know how many new boards and commissions that are created. I mean, I just feel like this is really growing to a point where you start to really see ineffectiveness coming out of it, and I think that's the opposite of what we're trying to get to.
Thank you, Jessica. Appreciate that.
Bill?
Thanks. I just want to express my support for this approach. I'm really impressed at the boldness of the waiver proposal, particularly with the emphasis on achieving equity through all these mechanisms, through expanding access, particularly on the work on transitions and the encouraging the spending or investments in health equity. So I'd be happy to sign a letter or support or sign a letter of support.
Brenda, any thoughts you want to share?
Yeah, I think what I was just cooking on it a little bit, but what's up for me, I think, is excuse me, just relative to the community collaboration and the investment funds. And I think one of the most critical points to address both Jessica's comment and what we're hearing in community is that there's just strong communication, and that the type of resource is really bright and knowable, so that the coordination between what one, excuse me, one group like our CACs within our CCOs are advocating for in terms of community investments, and the regional health equity coalitions are also kind of understanding where one body picks up and where the other leaves off, so that it's not, so it's kind of a broad platform of resource and support in community and not duplicative of effort. So I just wanted to say that as well. I also think that I just want to do a hats off, I think, to OHA, to the board, to the length of time in the deliberation of this particular 1115 waiver, specifically in feeling really informed about the process. And I support the direction. I also want to offer, when the chair is ready to, lean my vote toward a letter of support. I do have one remaining question, Jeremy, which is mostly for you, I think, about how this board will be informed during the deliberation process with CMS. What those updates might look like, over the several months where we're back and forth with CMS, and recognizing the 1115 waiver is not the only place to achieve some of what the state wants to accomplish, how you might inform us of where those winners and losers actually come into play.
Thanks, Brenda. I think we can certainly build in regular updates. As I mentioned, I'm expecting this process is going to be, 6 to 10 months probably. So I think we can certainly can build in updates for the board as we get through the process. It'll start out a bit ambiguous and get clearer as we get towards the end. Sort of the way the process works is a lot of questions and answers. We get a lot of questions from CMS. We're sort of already starting that process. And frankly, we sort of tried to read the tea leaves based on their questions. Are there things that they like or they don't like, or do they have concerns? And then eventually start to actually get to yes or no, we're willing to go here, we're willing to not go there. It's not usually a, maybe a negotiation in the sense of, everybody kind of draws out their positions and then you try to find a middle ground. It's sort of this discussion that goes back and forth as you're trying to figure out where are they willing to go, where are they not willing to go, and then continue to try to resolve their concerns and eventually figure out if for each of these policy decisions, whether they're willing to go there or not. So it'll be a bit murky for a little while, I think, until the spring. And then we'll start to get a better, clearer picture if there's some things that are just non-starters for them or not. I will say overall that very, very positive conversations with them. They're, I think policy goal wise, very aligned with where we're trying to go. Oftentimes it's just the precedent of the actual things we're asking for and whether they're willing to sort of set that precedent for other states that want to follow. But we can certainly build in, I think, updates at board meetings and as we get, if there's more substantive updates in between there, I think can build in a process to keep you all posted.
Kirsten, do you have thoughts you want to share on the letter of support?
Not that wouldn't be duplicative.
Okay. I want to just offer my support. I see this as receiving the permission that we need from the feds, the OHA needs from the feds to continue to move upstream, to have the creative levers to advance health equity, to address social determinants of health, to address, continue the progress of CCO 2.0 in innovative ways, and also for greater community engagement and power sharing. So I fully been following this through these meetings, but also through the HEC, and I think the HEC has been very engaged in these discussions as well. So I would gladly approve a letter of support. But I want John.
Yeah, David, along those same lines, and in response to Jessica's concerns, which are valid, this has also been robustly discussed at the Medicaid Advisory Committee. And the issues that Jessica raised were discussed there. And they have written a letter of support for the waiver. And in my own view, I think this is an evolution. We started with community advisory committees. I think this is a next step. I think, there's still a lot of issues that will evolve. And I think when it comes to equity, this is an issue that's going to need a robust approach. And we'll need the community advisory committees, for example, to be part of that, but we'll need to do more than those committees. So for the record, I want to make sure the board knows that the Medicaid Advisory Committee strongly supports the waiver.
Oscar, what are your thoughts on this?
Yeah, I'm very supportive of the letter. I would like to review it before it is finalized. But I definitely don't want to get into a group editing process. I echo Brenda's comments about feeling that the OHA team has done a great job at bringing the board along throughout the process and keeping us informed about the policy priorities and how they have evolved over the last 6+ months. Particularly, I just want to thank the OHA leadership on the waiver team for their work of doing community engagement during a pandemic. I'm sure that has not been easy. And also to really be able to make connections of, conversations, previous conversations, reports, things that are we've heard already, and making sure that you're lifting those voices into this waiver.
Thank you, Oscar. So Jessica, I just want to circle back, see if there's any concerns you want to address in more detail or questions.
I mean, in general, I am concerned. I'm concerned about just the overall cost of what we're doing. And one of the things that I think we often do in Oregon is that we spend a lot of money on the coordination piece. We make things more complicated than they need to be. And at the end of the day, those dollars don't make it down to the people where that really need them. And, all in good intentions of doing all the right things, but we have many systems that operate this way, and healthcare is exceptionally complicated. And I just think, you continuing to further complicate it makes it more expensive and could create another barrier to actually delivering the care that people need.
And is this something you would like to concern you about a letter of support or a process once we have?
No, I'm in support of the waiver, and I think it's really important. There's a lot of good things in there, but I do want to call out that we need to really think seriously about the processes that we have in place.
Great. Thank you for sharing that concern. I think it was well received and noted. Bill.
Yeah, I'll just comment on Jessica's concern. I think there is a legitimate concern to make sure that there's a trade-off. There's a balance between making sure that there's a process that is inclusive, that reaches out to people to make sure we have input from the community. We're not relying just on a group of experts or government employees or political leaders for these very important decisions. And this is a long tradition in Oregon that I think is unique and has strengthened us as a state. But it's possible to go overboard. And so I think a regular review of the kinds of processes, committees, advisory groups, and so on, with an eye toward making sure that when there's not overlap, there's not duplication, there's not unnecessary process or process we're kind of the flat of the curve in terms of getting community input would be good. Now, I'm new to the board this year. I'm assuming that the Health Authority has some kind of process like that to review all these groups and a big look. But I think just making sure that we have that, perhaps have the chance of the board to review that and discuss the issues of the trade-offs of making sure we have appropriate input versus grinding the gears unnecessarily. We can put in place a monitoring and review process like that hopefully doesn't add to our add another layer, but I think it's hopefully would be would result in, it's kind of like doing the spring the pruning every year in your garden. It's a good thing to do.
Thank you, Bill. Brenda.
Oh, it's fun to follow Bill on that. It's exactly where I was at, and just really asking for more follow-up, I think, from OHA around this specific issue, both by way of when, or should we be so fortunate as to be successful in the waiver application on the topic itself, and then when we get closer to thinking about implementation, that we have a deeper dive on the topic to both address, I think, Jessica, some of your concerns around duplication, cost, layering, how inclusion happens. That's, I think, what we're all aiming toward. But of course, as we all know, it gets really complex when we get into that, in its steps. So staying close to it and really asking OHA to give us an update as we get closer to it. Thanks.
So what I hear emerging from the group is a consensus of support for the letter of support, possibly with review of the letter by the board, but ongoing monitoring of the implementation of those processes, paying attention to the concerns Jessica raised around cost efficiency, and also making sure that the OHA has the tools to engage communities in advance equity. So it sounds like, since we had a fairly robust discussion, it seems like we should have a vote just to close this out. I'd like to entertain a motion for putting forward a letter of support for review and moving forward with OHA.
Yeah, David, I'd like to move that the chair of the board produce a letter of support for the 1115 waiver that reflects the discussion that we've had today.
Do I hear a second?
Second.
Any further discussion or comments? All right. All in favor? Aye.
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 Any opposed? Any abstentions? All right. So we'll, OHA will prepare a letter, we'll circulate it, and then please, if there's any concerns, let Oscar and I know, and those will be incorporated, and we'll move forward with submitting the letter with the letter of support with waiver. Thank you all for a great discussion.
We'll make sure to build in some regular updates, as well as to bring back some conversations around how the cost and financial pieces of this are moving forward. So make sure to keep the board apprised as we go ahead.
Thank you, as you always do. Today we had the pleasure of having Rachel, Public Health Director Rachel Banks, joining us today to share the OHA updates on behalf of Patrick Allen. Director Banks, great to have you here. We look forward to your update.
Thanks, it's great to be here. And as always, wishing Director Allen a speedy recovery. So what I plan to do, and I'm happy to take any questions, is go over a few updates. I'll start with an introduction. So for the record, my name is Rachel Banks. I use she, her, and hers. And for a visual description, I'm a Black woman sitting in an office with blue paint on the walls and big curly hair. So once again, thank you all. I just want to start with thanking you all for your service as the Oregon Health Policy Board and just your guidance in terms of equity and the variety of things that you have really provided leadership on, I think, particularly in the pandemic. So I had to get that in for my public health director roles to start with that appreciation. But what I hope to do today is provide you all with some COVID updates on things, current happenings, like where we are with mask requirements, of course, do some reflections on Black History Month as well. And then I'm happy to take any questions or comments or however the meeting works. So in terms of COVID and Omicron, we're clearly focused on the Omicron surge. Today, we've had just over about 5,000 cases with a test positivity rate at 21%. That's down from the 7-day average, about 25%, which we like to see. As folks know, and you can see in the reports and some of the modeling from OHSU and Dr. Peter Graven, and as we've seen with Omicron, have had a huge spike. We do anticipate that there will be a shoulder in that spike that we may not be seeing in the modeling. And then as we all hope that we're coming down, just a couple reminders on the downside in terms of cases and hospitalizations, that we will have just as many cases coming down from the peak, right? And hospitalizations as we would going up. So while we know that when folks see the downtrend and we're clearly cautiously optimistic that we want to put that flag out there as well, that coming down still has a severe and high number of cases. And then also just that hospitalizations is a lagging indicator. So as we're looking at case rates, we do anticipate that hospitalizations will follow and that we still may see some of those higher hospitalizations. So clearly our intent is to make sure that there's hospital capacity, that if any of us or our loved ones needed hospitalization for any reason, that there is those beds and the staff capacity there. We know that our healthcare system has worked tremendously hard over the past couple of years. And as an agency and with a variety of partners, we really want to bolster that workforce, the healthcare and the long-term care workforce. So many of our strategies have been to ensure that there are staffing and supports as we endure this surge, and of course, clearly surges before that. In terms of hospitalizations, we have seen 649 Oregonians that are hospitalized with COVID in the past week. That is a 12% increase over the past week. Once again, that's expected that as cases go up, those hospitalizations will go up as well. There, as of January 31st, there are, excuse me, let me turn this off here. So as of January 31st, there are 187 COVID-19 positive patients in intensive care. There are 66 available ICU beds, and that's out of 658 total, which is about 10% availability, and 277 available non-ICU beds, and that's over about 4,000, which is 7% availability. We do see varying regional constraints that we're watching across the hospital regions where capacity is thin, and once again, folks are clearly tired and whatnot. In terms of the things that we know help prevent the spread of COVID-19, help make sure there's capacity in the healthcare setting. A couple of those things that I'll talk about are vaccinations and universal mask wearing. In terms of vaccinations, Oregon is really leading the pack in terms of vaccinations. We have very high, or excuse me, boosters for folks. And so great, that's great. Since the governor announced a goal of wanting to get 1 million folks boosted, we have seen an additional over 500,000 booster shots given across the state of Oregon, which is fantastic. We're continuing to encourage those booster shots and primary shots as well. On our website, you can see where we are in terms of race and ethnicity. I can also, if we have time later, pull up some of the race and ethnicity and see the progress that has been made. Back in the summer, I guess it was, we had, working with communities of color, identified for the initial series an 80% goal, really wanting to set a high mark and be working with communities to get to that. We've made significant progress. We have more work to do, and just want to assure folks that we're continuing to work with communities on wherever they are in their vaccination series to continue to get vaccinated in their first primary series, and that booster availability, including a variety of different community-based strategies, culturally specific strategies, multilingual strategies, looking at all of our sites for accessibility analysis, just really trying to be as comprehensive and as focused as possible as we continue. So we will continue to do the work on boosters and vaccinations. In terms of where we rank with others, so Oregon ranks 12%, 12, excuse me, in the percentage of people 65 and older who are fully vaccinated, and 18th in total vaccination dose data overall. The other protective factor, as we know, is mask wearing. And so the mask requirements were operating under temporary rules, and according to Oregon statute, those temporary rules can last for 6 months and then need to transition into our structure for permanent rulemaking. So we are in the process of doing that now. There are 3 different elements to that as it relates to masks and vaccinations. One of them, the permanent rules were filed on Friday, which included masking in schools and vaccination of school staff. The other was healthcare workers, once again, masks and vaccinations, which were filed yesterday, if yesterday was Monday. And then the general public masking temporary rules go until February 8th, and we're in a process of reviewing feedback and then determining further action. Just in terms of some of the feedback we've heard for the rulemaking hearings, folks were very engaged and sharing testimony. We heard a range of concerns. I think there's also some confusion about what does permanent mask, I mean, it says permanent, so it clearly sounds like, is this forever? So we need to do our part in communicating that it's really switching over out of a temporary rulemaking. Masks are not permanent. The mask requirements, we have absolutely no intention of that. And really looking at things like hospitalizations, once again, hospital capacity, equity. We want to be watching and mindful if there are any additional variants of concern. So a variety of factors that we're looking at. I think the school setting has some unique elements in it. Clearly, they're children. We have lesser vaccination rates in that population, partially because vaccines weren't available as early. We also have children that are there for an extended period of time, hours and hours, and basically having a universal masking policy really protects those vulnerable students, students with disabilities, those who are not able to mask, or have other specific learning needs. So we really want to, obviously take special care with our school age population, as well as the educators and supporters that are working with them. We know that, having enough staff to operate a variety of settings has been a challenge with Omicron. So we want to also do everything that we can to make sure that we can get out of this surge with keeping as many kids in school as possible. So we will continue once again with those mask rules for the general public, and are looking at a variety of data. I can send to whomever, Tara or whoever can send out, or you can find the links to the report of what we heard in terms of both oral and written testimony, once again, with a variety of concerns and then also supports. So Oregonians are very engaged in this topic, and we will be talking about more what the rescinding of or what sort of things we'll be looking at as we transition out of mask wearing, which may and will likely include recommendations, encouragements for masking for certain populations or in certain settings. The other thing, I know you all will hear an update about legislative session, but happy first day of session, happy Black History Month, happy Lunar New Year, a variety of things happening on February 1st. So I won't go into the legislative session piece other to acknowledge it and know that you will hear from my phenomenal colleagues. In terms of thinking about Black History Month, particularly after talking about COVID, particularly after the past couple of years we have, and just, very personally thinking about myself being the first Black public health director in Oregon's history. In fact, the first person of color that's ever been a public health director in Oregon's history. It's hitting me particularly heavy and particularly joyful at the same time this year. I think, in terms of the themes are really around health and wellness for the National Black History Month themes, I think, which are perfectly timed. There's a definite route that we can look at from a historical perspective, from a current perspective, in terms of the inequities, particularly for Black Oregonians. COVID is an example. It's an example that illuminates those past inequities, which I know you all have talked about and seen data about. But I can say what I've had the privilege of being able to do and work with colleagues across the board in my career. I'm looking at, for example, Director Ebony Clark, who I see on my screen, and with a variety of other Black Oregonians, is just really the resilience, the joy, the pride, the innovation, the leadership, the foresight for us as a society, as a community, to get past where we are. Black Oregonians, Black Americans have always had that foresight, have always had that belief that we are striving towards a society that we may not yet be in. And I just want to give a shout out to, I work and have the pleasure of being the sponsor, for example, of the Black African American Employee Resource Group at OHA. And all of us at OHA are striving towards, such a noble goal in terms of eliminating health inequities by 2030. And really acknowledging that in order for us to be able to do that, we need to be working with the folks who have those experiences and listening to those solutions. So I work with a phenomenal group of folks who stand up and lead our employee resource group that I just want to shout out and tell some stories about the phenomenal brilliance of Black Oregonians and those folks working at OHA, if I can. So, for example, the co-chairs are Terrence Saunders and Jamar Summerfield. And these are folks who have phenomenal stories, who have a phenomenal history, who have a perseverance and a joy. And as this employee resource group has come together and worked together for collective learnings, I don't know if folks are familiar with some of the principles of Kwanzaa, collective effort, working together, definitely that health and wealth and really bringing forth that resilience. This is a group of folks who've done it. So I know that there are national unsung heroes and sung heroes, that there are historical figures, but just a personal reflection this morning as I think about what's happening right here, what's happening with folks who do the work and may never think or know that they will be realized for the work that they're doing. And just for all of the employees, colleagues that I get to work with who are working towards Black health every day. So with that, I will stop, and Jeremy and others happy to take questions or to take them offline or whatever makes the most sense.
Thank you, Director Banks. Any comments, questions? Ebony? Go ahead.
Hello, Director Banks. It's so good to see you. I'm gonna do my best not to get emotional, but it's just so, I just want to thank you for your ongoing commitment to this work. And I love the fact that the Oregon Health Policy Board and OHA were talking about Black History Month, and not only talking about remembering the atrocities of the past, but recognizing the brilliance and the excellence of current state and future state. And, I continue to just reflect over, the decades of just growing up and coming up in the system, and how equity and racial equity and just all of our values weren't where they're at now. And I just love how it's being reflected, how we're leaning in, how we're working to live that out. And I know that every day I just want to call it out, and I want to thank you and recognize you because of your courage and your boldness and what it takes to lead in one of the whitest states across the nation. And I want to say that, and I want to thank you for that. And I just, again, want to also thank just not only Governor Brown, but OHA as a whole for the commitment. And I just have to keep it real. When this is not necessarily popular, I appreciate OHA staying the course. And Director Banks, I just continue to appreciate, the influence that you've had in working to look at how do we better serve and bring equity to work to dismantle what we see across just the disparities across Oregon. So thank you for that. The one question that I just had also was just wanting to know, just from your perspective, what are some of the trends that we are seeing in some of our BIPOC populations specific to Black, Latinx, and Asian Pacific Islander? Are we starting to see trends go down in terms of test positivity and hospitalization? Is it kind of staying stagnant, or are we seeing an increase?
Yeah, thank you, Director Clark, and for the question and the comments, and being that Oregonian, born and raised, definitely raised, as I know we both are, and continuing to work towards that. I think, and if someone has slides I can kind of go through as well, or I'm happy to send something out. And generally, what we're seeing in terms of the inequities, and let's just take hospitalizations, has decreased as we look at them quarter over quarter. For example, with hospitalizations, I always get concerned about the race and ethnicity demographics of that, to be looking for those disproportionate impacts. Definitely with the Delta surge, for example, one of the first indicators that started ticking up before we got to the surge was Black hospitalizations. And I think that that's really something for us to be thinking about across when we're looking at data, because when, at that point, when you're seeing 5 times the rate of Black hospitalizations, but in a state like Oregon, the trends are going down, it really prompts us to look, and then to ask ourselves, was that really, the canary in the coal mine? So let me see if we keep going down. Thank you for bringing this up. So next slide. This is vaccine doses administered by rarest race and ethnicity. This isn't exactly what you were asking, Ebony, but while we're on it, I'll just spend a couple of seconds. where you can see broke it down and just for a visual description, the top lines are the green is Native Hawaiian and Pacific Islander, Asian is a turquoise blue, Black African American, African is red, followed by white and orange, and then we have American Indian, Alaskan Native in purple, Hispanic, Latino, Latina, Latinx in a greenish teal. I read those in the order of vaccination status. So starting with Native Hawaiian, Pacific Islander with the highest. We also know, working with communities, that we have some undercount issues there and visibility issues. What you see on the right side of the screen is the percentage of the previous week change and the current week change. So we are seeing increasing rates, and we have for communities of color and vaccinations, which is great. I mentioned we tracked an 80% goal, and we've continually seen that tick down. So for example, for Black Oregonians, we started, well over 35,000 Oregonians that would need to, Black Oregonians that would need to be vaccinated to get to 80. I think this slide deck is 2,000 or around 2,000. So we've been definitely moving through that. If we want to keep going to the next, here's the slide. So this is where we are left in terms of BIPOC communities, the Black, Indigenous, and people of color needing to reach the 80% vaccination goal for their primary series. This started over 200,000 when we were first looking at it, with the farthest to go in our Hispanic, Latino, Latina, Latinx community. If we keep going down to hospitalizations, which is, keep going, let's keep going past this, that's a 7-day average. Here's, keep going, thank you, that's age, community transmission, here we go. These are the cases by race and ethnicity, but I want to make sure that we get to the hospitalization question that Ms. Ebony had. So next slide, please. These are age-adjusted ratios by quarter and race and ethnicity. So you can see that we were highest in Q2 of 2020, but since declined. So the 1.0 reference point is if things were equal across the board. The top is Hispanic, Latino, Latinx, and then the bottom has American Indian, Alaskan Native in yellow, Asian in gray, Black in the navy, multiracial in orange, and Pacific Islander in the lighter blue. So we are continuing to make progress and decrease those gaps. And for some in this last quarter are what you would call at parity or equal. The next slide, the next couple slides go over this in a little bit more detail. This is hospitalizations by race. You have other at top. This is over time. And the next is followed by Black. So we continue to really look at those Black hospitalizations and be concerned there. And that's also why when we talk about things like mask wearing, universal mask wearing, and protecting hospital capacity, that is an inherent and implicit equity strategy. Knowing that this is what we're looking at when we have hospitalizations, and ultimately, right, everyone should be able to get the care that they need should they need to be hospitalized. Our Hispanic rates over time have really decreased. So earlier on in the pandemic, where the orange was much higher than the blue, and now we've seen that the orange comes underneath, the orange being Hispanic, is under the blue, which is not Hispanic. So seeing some good progress there in terms of hospitalization. There might be one other slide that's age adjusted. The next slide, please, is hospitalizations over time, age adjusted. We do have inequities that are persisting. We've seen them decrease, but have particular concerns still around those who are American Indian, Alaskan Native. Black, Hispanic, and Native Hawaiian are still more likely to be hospitalized than white persons. We've seen some decreases there for multiracial, for example, to get under that 1 point reference points, and this is age adjusted. So what you would expect based on people's age. The other one that we showed was overall. So I appreciate that question and the continued focus on us looking at these these demographics by race and ethnicity, and we'll continue to do that and continue to make progress. And ultimately, our goal is to have these gaps eliminated while the population overall is continuing to get healthier.
Thank you.
See, John has his hand raised.
Yeah, thank you, Rachel. That was terrific. And it's terrific to bring that data to bear. In the last month, 3 of my friends, all over 70, have gone into long-term care facilities. One of my friends has had major surgery for a life-threatening condition. What I just want to emphasize is the importance of what the state is doing in terms of bringing to bear the tools that protect the elderly and the immunosuppressed from being hospitalized and dying. It bothers me to see how often that connection's not made. All of those folks that I mentioned have grandchildren, have children. One couple has a wonderful adult child who's a teacher. One fellow has wonderful grandchildren. One of whom who's in daycare, and the daycare had to close down because of COVID. Folks my age, we love our grandchildren, we love our children, we want to see them. And if we don't wear masks and we don't get vaccinated, it's a minefield. My friend who had a surgery, just was keeping his fingers crossed the week before that he wouldn't get COVID and they would cancel it. So what you're doing is so important. And I just want you to know that I think older folks and immunosuppressed folks know that you're saving their lives. And thank you.
Thank you so much, and for bringing stories and life to our collective story as Oregonians and how interconnected it really is, and wishing the best for your friends as in their recovery.
Thank you. Jessica?
Yeah, so I actually listened to a lot of the testimony over the permanent, I guess, mask mandate and the vaccine mandates, and people are really upset about this issue. Can you tell me when is the decision going to be made what to do here? And I guess my question is, why are we talking about making this permanent when we have a lot of other states that are really opened back up? In a lot of, I mean, you look at what's going on in the UK, you look at, other places around the world, and we're kind of going in the opposite direction against, in many cases, what I'm hearing and what people are testifying to during that opportunity to have their voices heard.
Yeah, thank you for that. And thank you for listening in and the question and amplifying those voices. I think, one of the things that we've seen consistently about Oregon as it relates to other states is we fared much better. It's sometimes hard to do a one-for-one because we did this because there's a collection of strategies that Oregon's put together. There's similarly a collection of strategies or different things that other states have put together. But we have consistently and still do fare much better than many other states. So that's one of the things as we look at and we ask ourselves, what is Oregon doing relative to other states? We want to keep those outcomes front of mind. In terms of the mask, particularly, mask will not be permanent forever. I do understand that's confusing in terms of switching from a temporary rule to what is just labeled permanent rules, but a different sort of ongoing rulemaking process. And the things that we are concerned about, and to answer the question why, is that we know we are in the high point of our cases, higher than they've been. We've seen a surge like we've never seen. And we don't feel like it's the time to pull away protective measures, particularly for the folks that we've talked about, whether that be children, immunosuppressed, elderly, and in general, at a time where we have the highest cases and some of the highest hospitalizations. So we really want to get past this before we're looking at decreasing or eliminating some of those protections across the board. Definitely concur there are a range of opinions, and this is, people clearly do not want to see requirements for masks, nor do forever, nor do we. And I think that the comments have really demonstrated a range of concerns, and people want a holistic sense of health, whether that's, for children, for example, and where I think that we can agree is that we want children to be able to be in person, learning around each other from the highly qualified instructors and supports that they have, and that's really what we're trying to preserve as well.
So what happens if this goes into permanent rulemaking? What is the process for lifting that then?
So in the rules, there are a variety of things that we'll be looking at for lifting that, which includes hospital capacity, equity. Of course, we continue to look at cases, positivity, trends, and all of those things. And we continue to do that. We are doing that. Anticipate more information in the coming weeks as we are, every day and diligently examining where we are with hospital capacity, where we are with cases, ultimately increasing our vaccination rates is part of that strategy as well.
So why not just make it optional for local regions? Because then everybody's got that same profile at the same time.
Yeah, I mean, at this point, we're looking at a statewide strategy, right? And I think that becomes where we want to see that statewide protection. We know that there are variations across regions, and we do have a local public health system that's in place and working there as well. Once again, this will not be permanent statewide masking requirements, but it's definitely needed at this time. We manage our hospital system, for example. We really look across the state. While we do have regions, if any of those regions, and we do have regions that are, way too close for our liking in terms of filling up or not being able to accept patients. If any of those regions get in that place, we manage that from a statewide perspective, and then patients are transferred across the state. So I do understand that we have a regional or a local infrastructure, but we're also responsible to take a statewide look, and particularly around hospitalizations. We know that COVID doesn't stop at borders of counties or regions, and that's why we're really taking a statewide approach until we can make sure that we have the capacity that's needed. And I'm mindful of time. I know that there are a variety of questions. I'm happy to take them offline or folks direct folks there, but I want to stop. I know you all have other business, but I appreciate the time.
I think you might have missed the timing. When is their decision going to be made?
So there's timing, and the rules are in place now. That was the school rules were on Friday, the healthcare rules on Monday. The timing for the general public would be next week. So that is the timing for those rules at this time.
Let's take one last question from Oscar, and then we'll move on.
Just a quick comment, not a question. Thank you so much for the update, Director Banks. I just really want to acknowledge and celebrate that you are the first public health director, Black woman, person of color in that role. I know that probably places a lot of responsibility on your shoulders in addition to a very challenging job. So I just want to acknowledge that, celebrate that. And at the same time, make a comment that it's 2022. This is long overdue. This should have happened decades ago. This should have happened a long time ago. I want to also make a comment that, as we move forward in trying to achieve health equity as our 2030 goal, that we are laser focused on redistributing resources to those communities that have were intentionally made to be less healthy. So Thank you so much for all your work, and yeah, keep up the great work.
Thank you. Thank you, Director Banks. Appreciate the presentation and the discussion from the board. So let's move on to legislative updates. We're pleased to have the 2022 short legislative session now launched. The OHA Government Relations team is going to join us to give us an overview of the upcoming session. So thank you, Holly, Cynthia, Tristan, Isaiah, and Jeffrey for being with us here today.
Thank you. Holly Heiberg, she, her pronouns. I'm going to try out this, try to follow Rachel Banks' model. I am a white woman with long brown hair, sitting yet in another session from my armchair in my living room, which feels a little weird. So with that, I can tell you what we know as we start this short session. This is the first day of short session. The House met this morning and they have officially named their new speaker, Speaker Rayfield, and we are off and running. Next slide, please. You need no reminder of this, as this board has been so very important, focusing our work on health equity and the definition of that, and our 2030 goal of eliminating health inequities. As we start this session, our team tries to center itself on this goal and realize that our work is always to bring this goal forward into all of the work of session and work with legislators to think about how they're doing this work. Next slide. Dr. Bainsberg referred to our government relations team. We've had some changes since last we've come to talk to you, and each team member will have a little bit of time to talk about the things that we're initially seeing as important work that will help us move forward. And when I say us, Oregonians move forward, the go for health equity. Today, you will not hear from Jamie. She is not present for this presentation, but I just want to call her out for all of her hard work over the last year and a half to work with legislators, Rachel Banks, OHA leadership, the governor's office, to really move forward information where it needs to be in a timely manner on COVID. And she continues to do that work, but she will not be present today to talk to all of you. And I also want to call out Belle Shepherd, who you all know and love, who's played many roles at OHA, and she will be part of our team for a very short while, and then she is returning to the Innovator Agents team within OHA. And then you will also not hear today from Matthew Green, who does so much of our work, our communications work, and and Mary Beth, who, as Jeff Scroggin refers to her, is the force multiplier for our government relations team. She makes sure that we are all where we need to be and on time, which for me is no small feat. All right, let's move on. Just as a reminder, this is the short session, and that could be no truer. Each week we have a half-life for bills with major deadlines. So we're off today, it's first day, but very soon we'll have a first chamber posting deadline, and then we'll really see the fall off of a number of bills by that February 14th, which, as we know, is Oregon's birthday. And some people celebrate Valentine's Day, and we as a GR team will be feeling a little less pressure that day. All right, next slide. Just so you have the scope, it is very different for a short session than a long session. So far, and I do say so far because our teams are still looking at the bills that were dropped last week and doing their bill analysis. So we're still figuring this out. But right now we're looking at 259 bills. Those relating to health that we're tracking right now are 123. And then thus far, we've prioritized 37. And those prioritizations can certainly be about health equity. They can be about things that really impact the agency's business and how we would do business. And you'll hear a little bit, it could be all of those things plus maybe it's a bill that the governor has. So we'll talk a little bit about that as we run through the bills to highlight right now. Okay, next slide. So with that, I am going to turn this over to Cynthia, and we'll let each member of the team introduce themselves. Isela and Cynthia particularly, I don't think you've met with the Oregon Health Policy Board before, so take a little time to say who you are now that you've joined the team. All right.
Well, thank you very much, Holly. My name is Cynthia Bronger Munoz, and my pronouns are she, her, and I will go back and also describe myself. So I am a close to middle-aged woman with glasses and black hair and with a red stripe in the front. It's flaming red. And in the background, you'll see my children's pictures and my husband, and also just like a kind of brown wall in there. And I am super excited to be joining this fabulous team to be able to impact Oregonians and their health. I'm very excited for the work that's in front of us. And I'm going to talk about two bills, but I'll mention two other ones. And I just want to encourage people to make this a conversation. So if you have any questions, go ahead and stop me and ask them, because I do feel like this is more of a conversation than anything else. So please, yeah, and it's hard to see everybody on Zoom, so please just jump in, and I do not mind at all. So for public health, which is my policy area, the first bill I'm going to be talking about is HB 4052, which is racism as a public health crisis. Now, we did have a declaration that racism was a public health crisis, so this is a good first step in addressing racism as a public health crisis. So it is that a little bit of a follow-up on that. But it would create 2 mobile health units, and they would be pilots to see if we can extend that, if that is successful. And then it would be focusing on priority populations. And it would also create an affinity task group, task forces to make future recommendations. So that's kind of the way that this one is structured. And like I said, it does give us a step in the right direction to be able to address racism as a public health crisis. And then the next one is SB 1554. And this is an after action report for our COVID response, and it's at all levels of government that we're going to be looking at. And so it would be like the state and local governments, but it also will be looking at how community partners played a role in that. And that's been, I think that's really important to be looking at as well, to see how we can extend it, to see where holes are that we really need to fill. And it's a series of 3 reports. So it'll be a pretty long series of reports, and we're really going to try to look extensively and as many different places that we can fill holes in for future reference, to be able to bolster up our public health modernization as well. So this one could have quite an impact on how we move forward with any kind of health policy and in public health specifically. Any questions about these two? Okay, then also I'd like to mention that
yeah, I have a question, if that's okay.
Absolutely.
I have a question about this slide just went away. I think what I saw was about creating affinity group task force to make further recommendations, House Bill 4052. We've had a lot of conversations here on the board about making sure that community and consumer voice is lifted during these, groups and committees. And at the same time, we are, the other thing that we're noticing is that there's just a lot of requests, you know, for input, and a lot of work out there for committees and people getting engaged, which, you know, kind of puts a strain, particularly on those folks that we are trying to hear from the most. So I'm curious if, you know, there's conversations about how to mitigate that, or also how to align it with existing groups or committees that are working on this as well.
Yeah, well, there's been a lot of back and forth about the task force itself, and it is coming from some of our committees. Like, this was a recommendation from our oh my goodness, I'm not going to remember which committee it was, but it was a recommendation for one of our priority population committees to have task forces that are in charge of looking at where else we can help, so that it's not just a declaration, but it also is something that we can move forward and where we can move forward exactly. So I totally understand tapping into the community sometimes that are already pretty tight knit and small, right? But making sure that it's people that are already kind of involved as well, so that they know the issues that are there already. But this is a recommendation from one of our priority population committees. I don't know, did that answer your question? Yep, go ahead, Holly.
I was just going to add a little bit more texture or detail, which is the Oregon Public Health Association had a task force that was that this was their recommendation. This is what they wanted to bring forward. And so I hear that concern. In this case, what we're hearing is that the participants on that task force really want to create this infrastructure as an ongoing way to create input in what these mobile health units would look like, what criterion we would set, and then how we would create this path if what we would consider effective and what we would think is important to scale across the state. So it's sort of almost like a evolution in the way we would bring that task force work into a really collaborative place that is spelled out in the legislation. I think that is what they're looking for. But yes, we did also run this by our Division of Equity and Inclusion to think through what other groups are meeting and where to make sure that this would be set up for success. And I think that we're all in a pretty good spot that this particular bill and that method would lift up voices in a meaningful way and be a good use of people's time.
Thank you. That's helpful. I'm curious if there's conversations also about sort of providing payment for people's time on these committees as well. Again, if we're trying to get consumers or, you know, involved in this, trying to reduce barriers for their involvement.
Yes, that has been considered, and from my reading of the bill, I believe that it's in there as well. So yes, great questions.
Thank you.
Awesome. Any other questions before I think I still have time to talk about two other bills. Awesome. Okay, so another one I kind of just wanted to mention was HB 4099, which establishes a racial equity and justice youth collaborative. And really what this youth group would do is inform ODE as well as OHA and the Youth Development Division on youth topics, on racial justice and equity from youth. So they're looking at youth from 11 to 22 years old to be on this collaborative kind of it informs those three agencies, as well as the Legislative Assembly and the Governor's Office. So that one's personally exciting. I am coming from education, so I'm very excited about that one. And then finally, the Governor's Environmental Justice Task Force bill. It renames the task force into a council, and it also has a really awesome mapping tool. And that one is HB 4077. And that mapping tool would address some of the environmental justice issues with a map that kind of overlays different environmental factors for people's health. That agencies could use, but it would also be open for the public. That one's still kind of being worked out. Any questions about those? Okay, well, thank you. That was my portion. And again, I'm doing public health as well as tribes. I'm going to be taking over tribal policy as well.
Thank you, Cynthia.
Excellent. Thanks. I think we're ready for the next slide.
Good morning, everybody. I am Isela Ramos Gonzalez. I use she, her pronouns. I am Latina with long hair, long dark hair, straight. Two of my policy areas that I'll be touching on this morning are Measure 110 and the Oregon State Hospital. I apologize, this slide looks a little bit different, but in the Oregon State Hospital, there is a budget request for staffing to address the capacity issues. The capacity issues that the Oregon State Hospital is experiencing, along with a stakeholder engagement plan to address the aid and assist population there and the capacity issues that the Oregon State Hospital is experiencing. Next slide, please. Oh, and I think I'll pass it over to Tristan.
Hello, I am Tristan Fernandez. I use he, him pronouns, and I think I've been before you a few times. And I guess just following my colleagues, I don't have much hair, but so not much to say there. But I will just launch into behavioral health because it is one of the bigger areas that the legislature is focusing on and has had a focus on in the last few legislative sessions. And so starting it out, House Bill 4004, it requires OHA to distribute grants to the behavioral health providers for staff compensation, workforce retention, and recruitment. That actually already has a hearing date. It is going to be this Thursday in the morning at 8 a.m. OHA has been asked the CFO has actually been asked, Dave Baden, to come before the committee to kind of talk through some of the fiscal considerations that were put into OHA's analysis of what the cost would look like. And just to give you a little bit of kind of context and what I mean by some of these grants and what it's looking like, is they're looking at that 75% of these grants must be used for staff compensation, with the remainder of that portion being on retention and recruitment. And they're looking at structuring it in a similar way to the PPP loans that we saw from the federal government. House Bill 411 is targeted primarily at the children's system. It has kind of two components. It has student loan forgiveness for QMHAs, as well as a nursing market study specifically for children's intensive in-home services to determine the Medicaid reimbursement rates. And it would actually have a trigger in it, which if based on the study, that the study would be annual and it would require the legislature to amend those rates every year in conjunction with that study. So that's a approach, and it's something we've heard a lot about, specifically around rates in the system. Going off of that, House Bill 4012 actually is the language from 4011 as its own standalone bill, just kind of highlighting what kind of focus is on that children's system and the intensive behavioral health system, the children's behavioral health system, which has been experiencing difficulties. I'll quickly touch on House Bill 4083, but you'll hear a little bit more of that from Jeff Scroggins, who will follow me. But for the behavioral health component, it's seeking to address that it would prohibit health insurance policies and state medical assistance from denying coverage for services provided by behavioral health homes, and it would actually define these homes, and it would additionally prohibit requiring prior authorization for same-day services in those homes. The last one, House Bill 4126, it requires OHA to include language in any behavioral health contracting that providers must enter into agreements with any labor organizations that already exist representing their employees, and prohibits use of OHA funds to assist, promote, or deter union organization. And I think that's where I'll pause, and I'll turn it over to Jeff, I believe is next following me.
Thanks, Tristan. Can folks hear me?
Yes.
Oh, great. Thanks, Chair Arena. My name is Jeff Scroggin. I use he and him pronouns. I work in our government relations unit and support our health policy analytics division in our Office of Equity and Inclusion division. To follow my colleague's example and model the behavior, I appear as a white man and have a background with some books behind me. I have a brown scruffy facial hair at the moment and some curly brown hair on top. Can we go to the next slide, please? I wanted to kind of bring up a couple of workforce bills. You know, as we were preparing for this presentation, today is the first day of session, and I think we've counted, as of last night, no less than 13 different workforce related pieces of legislation. I will rattle those off really quickly. House Bill 4004, 4003, 4006, 4011, 4012, 4014, 4034, 4052, 4071, 4096, 4104, and then Senate Bill 1545 and Senate Bill 1549. I just share that to share workforce is on the agenda for the legislature this short session, and just wanted to kind of give an example of that universe to the degree it's helpful to do. I got a couple other bills on here that I wanted to point out. House Bill 4035 is a placeholder in the House Health Committee. I think you're going to hear a presentation later today from Director Van de Hey, which will kind of go into a little bit about the need for this legislation. And really, this is about just making sure that as we exit the public health emergency, folks on the Oregon Health Plan have continuity of care and access to coverage, and we don't lose any of the coverage gains that we've been able to make over the years as a state. And then, like Tristan mentioned, there's a primary care access bill, House Bill 4083, which is also in House Health. And that bill has both a behavioral health component and a physical health primary care component, and really builds on some of the work that the chair of that committee has been doing to stand up primary care as a focus area and ensure access to primary care and choice of providers for consumers as it relates to primary care. I'll pause there. I actually wanted to check in with my colleague Isela for a minute. I think, and this is probably my fault, some of her slides might have gotten lost in translation or not able to be submitted. So Isela, was there any other components of your portfolio you wanted to be sure to brief? And apologies for the slide snafu.
Thank you. And yes, I did want to mention a Measure 110 implementation update. There are two bills, SB 1541 and HB 4016, that combined would include $140 million per biennia reduction in Measure 110 funding. One of those is a committee bill in the Economic Recovery and Prosperity Committee, and one of those is a bill by Cano. So those have a significant negative impact on Measure 110 implementation. So I just wanted to ensure that the board was aware of those. And I also wanted to note that not only is today the first day of legislative session, today is also my colleague Cynthia's birthday. So if we have a moment at the end of the meeting or at some point, just wanted to wish her birthday, especially since we're all remote. We can't really celebrate in the same way that we would have. So I just wanted to acknowledge her birthday today.
Thanks, Isela. And I wanted to make, I'm gonna hit up my colleague too to wish her a happy birthday. I didn't know that. Estella just outed our colleague on her birthday today. That was fantastic. I want to make just one more quick note about the workforce bills. The agency is supporting the governor's, of course, the governor's workforce bill, Senate Bill 1545, Future Ready Oregon. I'll send some more information to Tara so she can distribute that to the board. And there's a lot of information available about this proposed investment, which would really lean on, what's working now and how we can use some of our in place trade boards and opportunities to really improve the pipeline in an equitable manner for workforce throughout Oregon, including healthcare, but also including other sectors like manufacturing. That's it for me, pending any questions from the board.
Any questions or comments?
Is there anything that the board can do to support your work?
I think that given where the board has been on racism as a public health crisis, it would probably be worth us sending some more information about that to the board. And for your all's consideration, you may want to reach out directly to the sponsor, Rep. Salinas, and co-sponsor, Rep. Prusak, and or to OPHA. We are really just lifting up and trying to educate you on their work and what they see, and make sure we're being a good partner as OHA. That would be one. We certainly would like the board to be very aware of what's going on in these attempts to take money away from behavioral health services that are primarily focused on Black and Brown people and people of English as a second language, which is a really important work going on with those Measure 110 funds. So we would appreciate it if you would take a stronger look at the good work that's underway. And the council's decision, which I believe is happening sometime this month, on how to award those funds. And it would really be a travesty if the legislature took the money away right when this money is finally going to be awarded to make such a big difference in our communities. And then I think Jeremy will talk to you about the work on redeterminations. We're very focused on making sure we don't lose the ground gained, and making sure people are insured in the state, especially people of color. So I think that's an area, again, if I had to say three things that I think really fit within the health equity definition that the board should take a strong look at and think about their positions and communication with others. Those would be the three things.
Thank you, Holly. Other questions or comments?
Can I just, go ahead, Brenda, go ahead.
Oh, just a quick request. I've always appreciated the legislative summaries, and thank you very much, everyone, for coming today and giving voice to the areas of your specific focus. I wonder if we, just in follow up to Jeff's litany of the number of workforce related bills, if we could get a bit more of a summary of each one of those, so that we can also do the same kind of work you're thinking about, Holly, in terms of connecting the dots with other areas that we're interested and involved in. Thanks for that. Yeah.
Thanks, Brenda. I'm just going to be really transparent. Yes, absolutely. The people we're having do that work, I think you may already know, and are heavily involved in the workforce committee. So I think we'll be able to share that analysis really quickly.
Okay, I have one more plug. I try to keep things to threes, and the workforce is important, so that's a fourth. So just to round it out for nature, because it goes in threes or fives. So the fifth, just to think about a little bit, and we're still forming this, is we really heard back, and DRO is supportive, and we've heard back from someone who's been hired between OHA and DRO to really look at how we shift and change to get people out of our state hospital when they need care in their communities. There was, and Zella's probably like, oh, Holly's not saying this the way that I would say it, but it's forming, and we can deliver more information as this report is coming out from Dr. Pinels. And I think this is really important because it's hard work. The idea is that we would share the risk of what happens when someone's ready to leave the state hospital with our county partners who can help find the placement in a community for Oregonians that need to receive care in their community. They don't need to be in a hospital. And this is hard, especially right now. We all are upfront. There's just not enough capacity in our community for that. And that is what some of this holdup is about. But it is also true that the burden, financial burden, rests upon the state and that person staying in the state hospital, and there is no risk to county governments and or this other capacity to share in that person staying in the state hospital instead of going to this community level of care. So we're trying to figure this out, and what is the right balance, and when would it make sense to sunrise a provision like this in the state? But we think it's a really important time to have that conversation with the legislature, because there's $130 million on the table to invest in local capacity. So it seems like these conversations go together. So that's my fifth, and now I'll be quiet.
Any less comments or questions? Well, I want to thank the government relations team for some really great summary, some really important work, especially during a short session. You're going to be really busy, but thank you for summarizing that for us and keeping us up to date. With that, we are ready for a break. We're doing well on time. Why don't we break and then reconvene at 10:20, and then we'll talk with Jeremy about redetermination. So look forward to seeing you all again at 10:20. Welcome back, everyone. Back to the Oregon Health Policy Board meeting. We will move on to a discussion of redetermination. In January, we heard from both Pat and Jeremy about the large number of Oregonians that will need to be redetermined for their healthcare coverage and whether they receive healthcare coverage from the Oregon Health Plan or the Oregon Health Insurance Marketplace. Over the last several weeks, the Health Insurance Marketplace Advisory Committee and OHA staff had several community conversations about how to approach this work. And today, Cheeky Flowers and Jeremy Vandehey will present those discussions and plans going forward for redetermination. So I hand it over to Cheeky and Jeremy.
Great, thanks, Chair Bingsberg. Cheeky and I are gonna tag team this a little bit. We're gonna talk a little bit about what has happened with insurance coverage generally through the pandemic. We're gonna talk about a report at a high level that was submitted to the legislature in December around public option, and then transition to spend the bulk of the time talking about redeterminations. We're going to talk a little bit about what the sort of current default plan is, absent any other policy direction, but then we'll end with some conversations that are being teed up in the legislature and how we're expecting those to unfold over the next couple of weeks. I want to say two things before I start. One, this will be a conversation that I think you all we'll be having together, and a topic you all will be hearing from us quite a bit over the next year and a half. This is a really significant challenge and important body of work that will be before us as an agency over the next year, as we're working through how to transition folks who've come in during the public health emergency as we get back into eligibility. And I'll talk about that in a few minutes. I also want to acknowledge some real exciting news that yesterday was actually a move day for the Marketplace team, moving from the Department of Consumer Business Services building over to the OHA building. We've been working on this transition for, I don't know, probably almost 2 years, is when conversations first started around would it make sense for the Marketplace to move over to OHA. And Chicky and her team have been doing a tremendous amount of work of working through that transition, getting through open enrollment, helping us think about redeterminations planning, thinking about all sorts of wild ideas of the future of the Marketplace, including things like public option, all at the same time, and have really been juggling a lot. And I want to acknowledge the amount of work that their team has been having to do to try to do their normal work while also transitioning over the agency and also trying to think about kind of future state. But more importantly, just really excited to have that kind of milestone of the move of the team over to OHA. We've been really excited to be working with them, and I think the redeterminations process that we'll talk about at the end will really demonstrate how important it is to have the Marketplace closely connected with Medicaid and other parts of OHA, where we're really trying to expand and provide continuous coverage to folks. Why don't we go to the next slide? Next slide. So we released some data a couple of weeks ago on from our biannual health insurance survey. We do a sample survey of about 8,000 Oregonians every 2 years. The last time we did this was in 2019, so right before the pandemic happened. And then we had the survey out in the field in 2021. It was out from January to September. So these numbers are already a little bit outdated in terms of COVID timelines, which seems like a month equals a year, but gives us our first indication of what's happened with insurance coverage through the pandemic. The main takeaway here is that the health insurance, the rate of uninsured folks in the state dropped from 6% to 4.6%. The primary reason for that is the issue we'll talk about when we get to redeterminations, which is the growth in Oregon Health Plan caseload. The individual market has stayed relatively flat, even through open enrollment that just ended the middle of last month. The Marketplace team had a very good year, and about 146,000 people enrolled. It's the highest number they've had in the last couple of years. But in the grand scheme of sort of where people are getting insurance, it's that those numbers have stayed relatively flat in about 140,000. Medicare has stayed pretty flat. But you can see here that overall what we call group coverage, which is people who get coverage through their employers, has been slowly ticking down over the last decade and dropped another couple percentage points over the last couple of years. So we've seen the employer market shift and continue to see people moving away from employer-sponsored coverage little bits at a time. But what we really saw here was a significant growth of folks who were previously uninsured moving on to the Oregon Health Plan, and that was really the biggest shift. And what you don't see here is also, I think, a really important data point around equity, which is we've not across every racial or ethnic group, but we saw some pretty significant reductions in inequities. We saw the rate of uninsurance for folks who are Black, African American in the state drop from 8% to 5%. And so I think that also shows the importance of Medicaid and the Oregon Health Plan in terms of expanding coverage and our goals around equity and reducing inequities. I'll talk a little bit more when we get to redeterminations. But the other thing that I think is really important to note is that we have seen the rate of what we call churn, people moving in and out of Medicaid, basically almost completely stop during the pandemic. That's because we have been continuously enrolling people and largely not terminating coverage for people on the Oregon Health Plan through the pandemic. And what we have seen is that pre-pandemic, about a third of our monthly applicants for the Oregon Health Plan had been on OHP at some point in the last year, about 25% at some point in the last 6 months. That's about 90,000 people a year who leave and come back. And so what we've done through the pandemic is we have basically stopped that. The only folks who are coming on the Oregon Health Plan have never been on, or they haven't been on for several years. And folks who normally are sort of going off and coming back at some point over the course of 6 months or a year are just staying on. And so the uninsured rate has gone down and the Oregon Health Plan enrollment has gone up as a result. I'm going to go to the next slide. I'm going to turn it over to Chicky to walk through a couple data points on the marketplace enrollment through open enrollment.
Thanks, Jeremy. So you can see in this slide so how our open enrollment has gone for the last couple of years. And when we had submitted these slides and when we got the final numbers from CMS, we actually ended up around 146,000, as Jeremy mentioned. And this is actually really fantastic number for the marketplace. And this is largely thanks to the ARPA subsidies. And these are the expanded subsidies beyond 400% FPL, and also increasing subsidies for those below 400% FPL. And this is the expanded subsidies that Oregonians have taken advantage of and people nationwide have taken advantage of, and is part of the conversation for the Build Back Better Act. So as I said, this is a great number for us, and we are thrilled that we ended marketplace open enrollment with that. And this is particularly important because in the last couple of years, the continuous coverage for Medicaid due to the public health emergency has not ended. So with continuous coverage, and we still have this high number, this is a great indicator that Oregonians value health insurance, at least for the marketplace side. Next slide, please. So this is a quick illustration of how the ARPA has truly been very beneficial for our state. Before and after ARPA, you can see the changes in the average premium after PTC or premium tax credits. You'll see before ARPA, it was around 145, and after ARPA, it went down to 84. So those are significant savings for Oregonians. Next slide, please. And I'll kick it back to Jeremy.
Thanks, Chicky. On the last slide, just to kind of close the loop on that. So what happened during the pandemic in one of the early recovery act bills is Congress increased the amount of tax credits in the marketplace, and so that brought down cost sharing and premiums, or at least out of pocket cost share. That was part of the Build Back Better plan to extend that, but that bill is not moving at the moment, and so it did appear that there was bipartisan support to continue those advanced tech or additional tax credits, but I think we're all waiting to see what will happen. But if they aren't extended, then that will mean, fortunately, costs will go back up for folks on the marketplace. But we're all hoping that they will be extended. Next slide. So as we've been thinking about where we're sort of going in terms of health insurance coverage in the state, in terms of future of plans on the marketplace, whether that's a public option or other plans, as well as thinking about broadly how are we trying to sort of evolve coverage to meet our goals. I think we've sort of rounded around some principles here through a number of conversations that have been happening over the years, and so we're sort of using this frame as we're thinking about our future planning, both in terms of things like public option, but also thinking about what we're going to do with redeterminations and options coming out of that. One has been really to focus on minimizing disruptions in care, not just coverage, but also care. Trying to reduce churn of folks who are going in and out of insurance coverage because of fluctuating income. That we're really doing more outreach and education around the options that are available and trying to keep people covered as much as we can throughout the year. Thinking about things like aligning provider networks, especially around primary care, so that as people go through life events and they're changing where they get their insurance, they aren't having to change who they're seen as a provider as much. We've talked last month about sort of how do we really align across markets, and are thinking about things like aligning quality and access standards, accountability for total cost of care, and really taking what we've expected in Medicaid around the system driving towards equity, and thinking about those in the commercial market. So this is just I think just a frame of common topics that have come up as we've thought about things like a public option or other ways to provide insurance coverage in the state, and what that would look like. Next slide. Next slide. So one thing we had to do last year, the legislature directed OHA to develop an implementation plan for a public option. This was in House Bill 2010. We developed that plan throughout the summer and fall, worked with OHA, worked across OHA and DCBS, worked with Manat Health consulting firm and some actuarial subcontractors that they had, and submitted a report at the end of December. I'll say a few things that happened while we were implementing that report that were unexpected. One, the pandemic continued on. I think even more so than many of us were expecting. This was sort of pre-Delta and pre-Omicron, and so I think as this was going on, realizing the pandemic and public health emergency were going to continue on longer than folks expected. There was the conversations that have been emerging around whether or not the tax credits would be extended through Build Back Better, and there were some conversations around adding more reinsurance dollars. So there's been a shifting federal landscape around what happens with the marketplace. And then I think that really we started to realize that as the public health emergency was going to continue on, this issue of Oregon Health Plan caseload and redeterminations is becoming a bigger and bigger issue that we are going to need to all grapple with. So those are some sort of shifting context things that happened, but we still developed the report and submitted it at the end of the month. Next slide. There were sort of four main goals as we looked at a potential public option. The first was really how do we build off the coordinated care model, and specifically how do we take elements from the coordinated care model and push those into the commercial market and marketplace plans in a way that really helps us drive towards equity. How could we really try to lower the costs, especially out-of-pocket costs for consumers? How would we leverage federal tax credits and federal support for any new plans? And how could we generally think about plans in the marketplace, and how do they better align with efforts that we're trying to do across CCOs and PEB and OEB and other places around things like cost and quality, equity, cost growth target, things of that nature. Next slide. So recommendations for the report were largely the sort of best option out there that aligned with our values. Appeared to be what Colorado is considering for a public option. Colorado is submitting a waiver request that basically requires insurers on the marketplace to hit 5, 10, and 15% premium reductions over a 3-year period. And what they're asking for from the federal government is basically share that savings with the state, that if they're able to reduce premiums by 5, 10, and 15%, the difference of that would go to the state, and the state could use it to further reduce out-of-pocket costs for consumers. Colorado submitted a waiver application this fall. We don't know yet whether the federal government's going to approve it or not, or where that conversation is going to go. But their idea is really to kind of standardize the market around these standard plans that have these cost growth targets. Next slide. So with all that said, that's sort of where we were at the end of December. As we've thought about public option and the work that's ahead of us in terms of coverage, we feel like the thing that's the sort of most urgent is actually thinking about what we're going to do around this redeterminations issue. So let me transition into that. I want to go to the next slide. So what's happened? Beginning in the beginning of 2020, when the pandemic first hit, Congress passed legislation that in essence required states to provide continuous coverage on Medicaid. I say in essence required because the way Medicaid works is that it's a state-federal partnership. The federal government funds 3/4 of the program. They aren't actually allowed to tell states specifically what to do because our Constitution doesn't allow that. So what they actually do is they pay states to do what they want you to do. So what they did is they gave states an enhanced match in exchange for states all doing continuous coverage. And what we meant by that was that we weren't disenrolling people for things like not providing timely information during redeterminations and things of that nature. Normally, as we're going through the process each month, we're going back through and determining eligibility for folks. There's people who will always fall off because their income went up or down, or they didn't submit information to us. And by and large, we have not been disenrolling those folks, with some exceptions for death, if folks move out of the state, incarceration, or if they voluntarily called us and said they had a change of circumstance and want to be removed. But by and large, we've been keeping folks on the Oregon Health Plan and not have been terminating coverage. And that was purposeful. That was because we were in a pandemic, and it's really important for people to be insured and be able to have access to the health system. This was all tied to the end date of the public health emergency, and that has been the federal public health emergency, that's been extended in 90-day increments. And so each time the federal government has extended the public health emergency, it has also extended this policy nationally of pausing on disenrolling folks from Medicaid. The public health, these slides are a little outdated now, but the public health emergency was set to expire on January 16th. 2 days before that, they extended it out another 90 days. So it's now scheduled for April 16th. There's all sorts of rumors that will be extended again. We don't know. Each time they've extended it, a day or two before the expiration. So we don't know exactly how long it's going to go. But we know that we're having to prepare for at some point it will end, and at some point we will go back to basically the normal eligibility redetermination process. The caseloads increased about 27% since we implemented this policy. I think we can go to the next slide. And you can just see the growth here. This starts at 1 million at the bottom, so it's a little skewed, but we've gone from just under 1.1 million folks on the Oregon Health Plan to just under 1.4 million folks on the Oregon Health Plan. Our forecasting team is estimating that once we get back in the normal redetermination cycle, about 300,000 people will come back off the Oregon Health Plan. That doesn't mean that 300,000 people came on and those exact 300,000 people will come off. What it means is that we will have to do an eligibility determination for all 1.4 million people. And when we do that, they're estimating that about 300,000 people will no longer be eligible or will come off due to sort of the normal unfortunate process of people losing coverage because they, are struggling to figure out how to navigate the process or don't return paperwork on time. Next slide. There's been some really, I think, positive things that we've learned through the pandemic, and some things that we're putting into place permanently to try to maintain coverage for folks, especially folks who are eligible, but like I said, get sort of kicked out each time we go through an eligibility determination, even though they're eligible. One of the things that was allowed was states could, that states were allowed to have folks basically self-attest to a lot of eligibility criteria. And so we've been basically allowing people, we've sort of been taking people at their word with the exception of citizenship or immigration status. One of the things that we're looking to do more permanently is to be able to allow people to self-attest to income, get them in, and then go back and do a verification, as opposed to what we used to do, which was we would wait till we verified income, and meanwhile those folks would not be without insurance until we were able to do that, and then we would bring them on. There's been expansion of presumptive eligibility and more flexibility around hospitals and partners to be able to do remote assistance to be able to help enroll folks. And I do want to note that we're talking about the sort of redetermination cycle, but it's a bit of a misnomer. We have been doing eligibility redeterminations throughout this process. We haven't been disenrolling people for folks who we can't do the complete eligibility redetermination. So what we have in the caseload right now is a mix. We have folks who have been going through the normal process. We have determined that they are still eligible and have stayed in. And we have folks who came in, appeared to be eligible, at some point haven't gotten updated information, didn't complete information, and we don't know yet if they're still eligible or not. And so that's what the process that we'll have to go through. I want to go to the next slide. The federal guidance on this has been a bit of a moving target, but we had our first sort of kickoff meeting with CMS last week around how we'll be planning for getting back into the normal redetermination cycle post public health emergency. What they have told us so far is that they'll give us 60 days notice of the public health emergency ending. So in theory, that means if we get to the middle of February and they haven't told us it's going to end, that we should expect it's going to be some point after April, because that's sort of when the 60-day clock ends. But like I said, we haven't actually been usually getting that queue until very close to the expiration date. They've given us guidance on how some basic sideboards around how to do this process. One, states will have 12 months from the end of the public health emergency to get to do redeterminations for everybody in their entire caseload. So every state will have to do an individual redetermination for every person on their caseload, and they'll have a year to do that. We have 4 months to ramp up. But within 4 months after the public health emergency, have to be on track and have to wrap it up another 8 months later. They've also given states guidance that they expect that we do basically a sort of a fresh look at every person on the caseload. What they don't want is states kicking people off because of outdated information. And so it may be, part of the challenge here is, especially when we're talking about folks whose income is fluctuating, is they may be eligible yesterday and not tomorrow, but they might be eligible the next day after. I mean, not literally, but functionally, that's how it could be happening, is that we have been holding people on for 2 years. It's not that we've been holding people on who are just ineligible. You might have had somebody who was eligible in year 1, and 6 months later, their income went up and they were no longer eligible. By the time we get around to doing the redetermination, they might be eligible again. So they are very worried about some states that will just basically terminate coverage for anybody who has outdated information or appeared at some point in the past not to be eligible. And they've said that's not going to be allowed. We have to go in and do a fresh look at everybody. Next slide. So our current plan right now, and then we'll get to some variations on how we're thinking about this. The current plan right now is really to go kind of go back to the normal cycle that we have, and to spread the 1.4 million folks that we'll have to do an eligibility determination for out over the course of 12 months. So basically 1.4 million folks divided by 12, that's the number of monthly applications that we'll have to do. We do have a mostly automated process for doing eligibility redeterminations with our one system. So most folks can go through this process in a fairly automated way. But there are some exceptions to that. And there's some for folks we can't determine automatically based on information we already have, whether or not they're eligible or not. The plan is to send them a pre-populated renewal notice. There's also going to be a lot of folks in there that we'd have outdated contact information for. They've moved or something along those lines. And so that's a big concern that we and a lot of states have is not being able to reach folks who may still be eligible, but something has happened with their contact information over the last year, and they don't get the notice. We expect this to really be a very robust outreach plan that's going to be needed. We've been saying this is going to really need to be all hands on deck. Thinking about 1.4 million people going through an eligibility determination, that's something we do on a normal basis. We do that generally. The issue here really is that we haven't been doing as much of it on a normal cycle as we have in the past, and so it's going to be confusing to folks. Like I said, a lot of people who have outdated contact information. So we really are going to need an all hands on deck across partners, CCOs, brokers, navigators, sort of everybody out there to know what's happening once we start this process, so that whoever is closest to the members can help them navigate and help them work through the process as much as possible. But our sort of default, without other direction from the legislature, which again, I'll talk about some options, variants of this, would basically be the month after the public health emergency ends, we'll start going through, 1/12 of the 1.4 million folks on a monthly basis. Those folks who can be automatically renewed will go through that. Those folks who cannot be automatically renewed will receive a pre-populated notice, would have 30 days to respond. And for those who don't appear to be eligible, we would do a data transfer over to the marketplace for Chicky's team to follow up. Next slide. Chicky, to you on what you guys do once you get data from us, or I shouldn't say from us, from the OHP team.
Yes. So in the last slide, you will see there was a bullet there that says if somebody was determined no longer eligible for the Oregon Health Plan, their information will be transferred to healthcare.gov. That's our current world as is. But Jeremy also mentioned earlier that potentially 300,000 Oregonians will no longer be eligible for the Oregon Health Plan. And how many of those are eligible for the Part Marketplace? We don't know the exact number, but my team and I were assuming 300,000. So there will be a handoff to healthcare.gov, but what we're going to do differently for the public health emergency unwinding is we really truly want to provide a personalized experience for these 300,000 folks. So their information gets transferred to healthcare.gov. We also get that information. So we are going to try to do two things for now. Our current plan is truly look at the Oregonians' CCO usage in terms of what based on their claims, based on their provider, and try to find the next best marketplace plan that hopefully will offer comprehensive coverage, continuity of care, hopefully continuity of care with their provider, and all these things that are valuable to the Oregonians. So that's piece one. And option two also is providing the Oregonians some options in terms of what is the lowest cost silver plan or any plan in your area that might be beneficial for you and your family. So looking at premiums, looking at out-of-pocket costs, and really truly providing them with their options of their best marketplace plan that we can crosswalk, or just tell them their options so that they can make the best choice for themselves. And then targeted outreach. We will, of course, can't do this work without our very our awesome community partners and insurance agents. It will be all hands on deck for OHA, DHS, DCBS, and of course our community partners and our insurance agents. And then the consumer starts the enrollment. They can contact us to help them with their enrollment. They can go through a health insurance agent or a sister firm, or they can go directly to healthcare.gov. While this sounds simple in theory, please know that this is a very highly manual process. Our caseload of about 300,000 folks, we estimate about maybe 2 hours per person to make sure that we can provide them with as much information as possible so that they can make best choice. Next slide, please.
So I'll just kind of close out here with, I think, some outstanding issues and how I think this conversation is going to play out, at least in the next couple of weeks with the legislature. There are a number of outstanding planning issues that we're trying to plan around and think about various alternatives or other options that we should be considering. Some of the issues include, we don't know when the public health emergency is going to for sure end. We're sort of having to operate off, it will end in April, but like I said, there's all sorts of rumors out there. The Build Back Better legislation would have actually set its own timeline and statute. So in addition to not knowing what the what the secretary is going to do and how long they're going to he's going to extend that out. We don't know. Congress could jump in at any time and set this for us. So that's another kind of timing issue that we're struggling with. I think the other timing issue in the midst of this is recognizing that we have kind of a standard process where basically, you know, folks have 30 days to respond, and if they don't respond or they provide information that makes it appear they're ineligible, then they start moving in the disenrollment process. When we're talking about the scale of 300,000 people shifting off the Oregon Health Plan to some other place, I think we're trying to figure out what's a reasonable amount of timing to be able to do adequate outreach to folks. That we're really talking about an exit that's much bigger than anything we've ever experienced in the past. And so should we have a different timing in terms of the amount of time people have to respond and the amount of outreach that we're doing to try to get them transition? We're trying to nail down resource needs, both internal in terms of staffing and caseload. One of the challenges in this is that, you know, as the caseload has grown, that's put more pressure on our ODHS partners who do the eligibility determinations. While at the same time, caseload for all human services has increased. So there's an across the board increase in terms of human service caseload for the state, and that's putting pressure on staff internally. We're also trying to figure out, though, what is the outreach, you know, what's the external need for outreach in enrollment. I've been sort of saying that, I mean, this is to me to the scale of something we have not experienced before as a state in terms of the number of people that we're trying to reach out to and trying to help land them in coverage somewhere else. And so what sort of level of support do we need for our community partners to help with this? One of the big challenges that we're facing is around the federal marketplace platform, the federal technology, healthcare.gov, as Chicky said. We have some limitations that do create some challenges for us because we're using the federal platform, things we had not considered pre-pandemic when we were on that platform. There's a number of challenges with that platform, but we're having some new issues now. It's very difficult to get timely information out of them on what's happening, and there's also no ability to do sort of an auto enrollment process. So, you know, we can auto disenroll people from Medicaid. We can't auto transfer them over to the marketplace. So that means there needs to actually be, you know, manual outreach, and folks have to go to healthcare.gov themselves and actually sign in and create an account and effectuate coverage that way. So it's a very manual process. And then finally, a big thing we've been considering, kind of going back to one of the earlier slides, is at the end of the day here, what we're really trying to do is provide access to healthcare for folks, whether they ultimately are in the marketplace, whether they're going to go back to employer-sponsored coverage, whether they're going to stay in a CCO. What we don't want to do is lose folks, and we especially don't want to create gaps in the relationship to the healthcare system and their providers. And so we've been thinking about, are there things we should be doing in terms of plans in the marketplace that help smooth the transition if people are moving from a CCO to the marketplace, trying to match them with plans that allow them to keep their primary care provider, or making sure that networks are more aligned across those markets. Next slide. So what we've been doing over the last month, Chicky and her team held listening sessions in January 18th and January 20th with community partners and the public around kind of the future state of the marketplace, and some input on how we options for dealing with redeterminations challenge in front of us. And the Marketplace Advisory Committee also met last week and endorsed some principles around the importance of continuity of coverage and really smoothing this transition. We've also begun conversations with legislators. Representative Prusak has a work group that met last week and will be meeting again tomorrow. And we're starting to think about, I think, trying to hold two concepts in our head at the same time if we can. One, we have to work through the redeterminations process. We're going to have to do that, and we've got to do that thoughtfully and methodically. At the same time, recognizing that there's only 146,000 people in the marketplace. The idea of transferring 300,000 people over is a little mind-boggling. And I think we've also recognized that a lot of the folks who are on the Oregon Health Plan right now were just previously uninsured. It's not like there was a mass exodus from the marketplace to the Oregon Health Plan and now they're going to go back. This is largely folks who There'll be some folks who will go back to employer sponsored coverage. There'll be certainly folks that want to pick up coverage on the marketplace, but there's a lot of folks in this caseload who were uninsured or were on the Oregon Health Plan at some point in a short period in the past and are very likely to become uninsured and then come back onto the Oregon Health Plan. And so while we're getting caught up on the redeterminations, should we be thinking about a better sort of program or landing pad for folks who are in this churn population? So we've started to idea has emerged around sort of a public option light, if you will, of can we really create maybe take some of the federal funding that would be allowed for the marketplace and create a spot where folks can stay with their CCO up to a higher income level above 138%. And thinking maybe more like 138 to 200% if folks are in that category, give them the option to remain with their CCO and smooth that transition. And so that's a conversation that we'll be having with the legislature. I think we'll be looking for direction on the overall timeline and process. The longer people are on the Oregon Health Plan, the larger the budget impact. And so there's a cost piece of that, but there's also a cost of doing this too quickly and not in a way that we preserve coverage and losing a lot of folks in the process. So over the next 2 weeks, expect to be having basically kind of pricing out and putting some of those options in front of the legislature around the timing of this, how we smooth out over a period of time, and as well as the potential for some options for creating a new program that would allow folks that are at risk of bouncing back and forth to land somewhere more permanently. No, that was a lot. We just really wanted to make sure that we gave you all an update on a conversation I think will be emerging and happening, but happy to take questions or feedback or thoughts.
Great. Thanks, Jeremy. Thanks, Shiki. We'll open up for comments and questions from the board. John?
Well, gosh, yeah, quite the societal phenomenon. It's very good that you're here and you're anticipating this. And kudos to you all for doing it. As you know, frankly, I would have very little confidence that the markets on either side here could solve this in a reasonable way without a lot of oversight and guidance. And it's great that you're going to try to do that, but very tough work. My sense from past experience is if you look at that 300,000 person population, probably 30 to 50,000 of those people are in the midst of an illness. Something significant is happening to them. And a subset of them are in the midst of a catastrophic illness. And in general, I wonder if the players here can identify those folks because they need to be in a different lifeboat. I think in many cases, I have to believe that an organization like Care Oregon could figure out, who are the folks who are in the midst of getting treatment for their hepatitis C, who are on transplant lists, who are in the midst of chemotherapy, who need life-saving but elective surgery, who catching them in between could really be a challenge, and figure out a solution for them. So that's one thing. As I think I mentioned it at one session, and Shiki knows this, are there subsets of folks, like 64 to 65-year-olds are very high risk, but they're all going to be on Medicare. You got 12 months. None of your 64-year-olds, I would argue, need to be transferred to the marketplace. Just let them wait. Will you let them wait and move them to Medicare? Because you do have 12 months. And I think there may be some other folks like that. That you can, provide kind of orderly solutions for high-risk folks who may not be in the midst of a significant illness. And even, I think, Chiki, when you mentioned the brokers, I'm impressed. The brokers do know what's going on. They're talking to these people one-on-one. And sometimes they are the people who will know, do you guys know what this person's in the midst of? Can we put them on an island for a while, let them get done with their illness, and then move them? I just hope you could, organize with CCOs, with organizations like Kaiser and Care Oregon and the county clinics and all. A series of lifeboats for the people whose health situations are unstable, and you've got to be very careful about moving them in this period of time.
Thanks, John. That's really helpful. And we have been thinking about, as I said, the default would sort of be you spread evenly 1.4 million out over 12 months. And we've said we need to be talking about other alternatives to that. And one of the alternatives we've been talking about is, are there phases, or should we be grouping people differently? And I think your suggestions around looking at folks who are undergoing treatment or higher risk. We've been thinking about high risk of becoming uninsured, but I think the high risk around people needing continuity of care is important as well. And that's definitely on our minds of trying to think through how to do that. So really appreciate those suggestions.
Thanks, John. Thanks, Jeremy. Bill?
Yeah. Thanks very much, Ken, for this presentation. This is an enormous and complex task. I wanted to first applaud you for the advanced planning, also for this doing this in a coordinated way between the Oregon Health Plan and the marketplace. Also wanted to support very much what John just said, that to focus on those who are in the midst of treatment, especially those with serious conditions. And that more broadly, rather than thinking of this as 300,000 people we need to do something with, to really, to use a marketing term, segment the market, identify those in most need, and prioritize those to make sure that they get special attention to ensure there are not gaps in care, as well as coverage. You may already be doing that. I didn't come out as clearly in the presentation, but that'll be a really important thing to do. A question about resources. As I was listening to this, the former budget chief and CFO, I felt like, oh my God, this is going to take an enormous amount of work. All these redeterminations, all the people flooding into the CCOs and their intake processes. Maybe just a big question: does the Oregon Health Authority, do the CCOs have the resources to pull this off? This is enormous. Or does there need to be additional resources or redirected resources to be able to accomplish this?
There will need to be more resources to, and it's one of those things where it's like, how smooth of a transition, the more resources, the smoother the transition, right? But there will need to be resources both internally and externally. I think both internally in terms of caseload staff, but also externally thinking about outreach and enrollment. Kind of give a parallel here. We had about 350,000 people come on the Oregon Health Plan when we launched the ACA, but that was largely due to that was in a large part due to a fast track enrollment process where we looked at people who were eligible for SNAP and then allowed them to come in. So the scale of outreach and enrollment to 300,000 people, I think, is something that we've never really fully grasped before, or dealt with before. And so trying to get our arms around what does that actually look like, and what types of resources should there be in the community is something that there's definitely going to be resources. We're trying to work through penciling that out exactly, both internal staff need, but also externally community partner need. I mean, the scale here is, on average about 25,000 people leaving a month if we didn't stagger things differently. And so thinking about transitioning 25,000 people every month somewhere else is a big lift. This is not an Oregon only problem. Every state is dealing with this. And at the same time, there's been a lot of workforce challenges with the state, like in every industry, of trying to retain people. So not to be a Debbie Downer, but we're trying to sort of balance all of those things. And frankly, that's all the reason why we're looking at longer transition periods and looking at places like, a program where we could land the churn population to try to smooth out that coverage, because, we are worried that, we are just worried about trying to get through all this in 12 months and with the least amount of disruption to individuals.
Well, please keep us posted on that. And particularly occurs to me that, like you say, it's a problem for all the states and territories, which sounds like it should be brought to the federal level, and Congress ought to be made aware of this. I know there's been some talk about a new COVID relief bill, although it's been talked about as in relation to Omicron. This is kind of like coming out of the public health emergency. There's enormous transition costs, and states ought to get some support for that. So please keep us posted on that, and if there's anything we can do to help, in terms of with a congressional delegation or with Congress generally. Last thing is a request is, as you go through this and report back to us on progress, plans and progress, you were probably already going to do this, but please keep in mind and looking through this through an equity lens to make sure that all the things we've been tracking in terms of like the information we saw earlier about immunizations and boosters and hospitalizations by different racial and ethnic groups. Please, we would like to see, I think we'd all like to see information on that, about plans to make sure that this whole process that you described is being done in a way that doesn't make the inequities worse, or preserves the gains we've made in terms of over the last several years in equity.
Thank you, Bill. Kirsten?
I agree with everything that has been said thus far by my colleagues. I also just want to call out something really hard, and I'm sorry, because I think that like the intention here is good, but I am really worried that we will go through this incredible task that you have laid out before us that is very hard and complex. And let's say that it goes all as planned. At the end of that, I think that we will not be able to call that a success in our state's broader goals towards ending health inequities. And that is my deep concern here, because I feel like this, especially this churn population, and Jeremy, you mentioned the decrease in uninsured rates among Black Oregonians, which is incredible, right? That is forward momentum. My concern here is that we will go through an effort to try to move this population onto the exchange. Some will elect to not go because they cannot afford it, even with the subsidies. Some will go and will now have, let's say, $84 a month expense, or maybe even less than that. I think 70, when I plugged in the numbers, okay, let's say I earn 200% of FPL, I will have a $70 a month expense now. And just to put that in true numbers, this is someone probably earning $16 an hour, $35,000 a year, and supporting a family of 2. And now I'm going to have an extra expense of $70+ a month. That is not acceptable or doable. It's going to come at the expense of food, or it will cause stress. And I know I have said this, I'm like a broken record. Income is the biggest predictor of health. And we are going to ask people, or not, we're not asking them. There's an unfortunate situation here that we are dealing with, where we are going to ask people in this churn population in vulnerable place anyway to take on an extra expense to protect their health, but that will come at the expense of their health. And so I feel like we are in a difficult situation here, where it will be hard for us to truly succeed, even if all goes as plans. And so I know in the midst of us having to plan for this incredible lift and work, and I hear so many good considerations going into it, I feel like we have to stretch to say, like, is there another way to do this at this time? And you know, I think Jeremy, you alluded to that at the end of your presentation, and that too is intimidating to think about how we do that in a short timeline right now. But I guess I would just like to urge us that we don't have a choice here, because if we don't figure something else out, we have a daunting task that won't get us any farther ahead in our goals, unfortunately, and is asking so much of incredible people to hand walk through that process. And so I want to I do respect the work that has gone into outlining that difficult process, and we don't have any choice other than to plan for this scenario. But I really urge us to, if we're serious about our goals and what we've repeatedly said as this board and as a state, we have to figure out something different here to land this churn population, to not have a churn population, right? People need that continuity of care without an additional expense. And so we need another solution.
Thank you, Kirsten. Well said.
I'd like to just comment on that as well. I think that this is causing also another issue, which is people aren't advancing in their careers because they are trying to balance staying under that eligibility level in order to continue getting the healthcare and the other resources that they need. And so what we see is that we've got a very, very tight workforce in Oregon and in other places as well. But people are sitting it out. They're basically hunkered down. They're not advancing their careers the way that I think industry needs. And the systems and the structure that we have in place that are supposed to, help people kind of make that transition, that smooth transition to advancing their income and really improving livability here. They're really trapped, and so I agree with you, Kristen, that there needs to be a better solution here. And I've been taking a look at this concept called the Public Assistance Offset Program, where it basically allows people as their income grows to pay in to help shore up that benefit system, but it also allows them to stay on longer term and prevents that churn from happening based on income eligibility. And I think if we're really serious about preventing that, this might be the time to really take a look at what needs to happen as far as removing the barriers in order to put in place a system that really helps to smooth out that process. Because we know if people are on SNAP, if they're receiving TANF, if they're on Medicaid, when they start to pop out of that eligibility, those programs drop off and people can't afford to go on to, let's say, the exchange. It's just not doable. You're talking not just $84, you're talking hundreds of dollars, depending on how old they are and how many people they are insuring. And so what they'll do is they will ensure that they will not pop out of that eligibility range to make sure that their family is covered. And until we deal with that system, we're going to continue having this problem.
Thank you, Jessica. John?
Yeah, as Kirsten spoke, I wondered, I've heard from many colleagues, and it was true when I practiced. It got so frustrating during transitions like this when folks would change systems. So you'd have new people coming in, and the expense of that new person to a system, when they were actually happy in their previous system, they just didn't now have it. Their employer had decided to, reduce their options or whatever. Is there a way to use a dangerous word, to monetize that efficiency? In other words, if like Cheeky, I've got to give Pacific Source credit. At one of your sessions, the Pacific Source person spoke up and said, hey, we've got a CCO, we've got a marketplace plan. We're actively trying to figure out a smooth transition for folks from one to the other. When folks are willing to stay with their health system, could there be some incentive for that in terms of waiving cost sharing for a period of time to make that smoother for them? Because their providers are going to be saved from the expense of a new bunch of folks. I mean, I'm sure you will hear from primary care folks, oh my gosh, 300,000 people are going to be out there coming in as new patients when we can hardly have the manpower to see the folks that we're supposed to now. This is just going to be so inefficient. So would there be a way to incent and protect for a period of time folks who will stay in the same system?
John, Jeremy, do you want to respond to those? I think Kirsten has another point.
I think all of this is great conversation. I think this is all this types of stuff that we're sort of throwing against the wall. I think we all internally have the same values around not losing folks and appreciate the conversation and are trying to figure out how to navigate this through a legislature in a 35-day session when then this is a long session conversation. And unfortunately, we don't have a long session before we're likely going to have to get into this. And so we're trying to figure out, how to throw some, some wild ideas that aren't as planned as we would normally like to have in front of the legislature because of the fact that this is sort of the one bite at the apple. I think, roughly what we've been considering is a series of potential steps that, are not mutually exclusive necessarily or sort of build on one another, but do have some costs, or at least some initial costs in the meantime. I think we have been, as I mentioned earlier, thinking about in that 12-month period, or should we be thinking about doing the redeterminations in some type of priority that, has some people on the front end or back end of that based off of, a set of criteria. It could be risk of treatment. I think that's or risk of a break in treatment. I think that's an important one. We've thought about other things like folks who are at risk of losing coverage or churn, or we may know that we have incomplete information. One big challenge that I do want to highlight is it's not like we know who these 300,000 people are. This is from our forecasting team, who basically looks at sort of economic indicators, what's happening with income in the state. And so their estimate is when we look at the 1.4 million, we'll find 300,000 people in there who are no longer eligible at that point in time. They may be eligible 6 months again, right? So that's a bit of the challenge as you're thinking about staggering it. But it's not like we know who these 300,000 people are. It's not like there's 300,000 people who are in the Oregon Health Plan who are ineligible, and we know that. It's an estimate of once we go through this process. We have also been looking at some longer term options around basic health plan was an idea that emerged years ago around you could take federal dollars that were in the marketplace and do something different with them for folks for 130 to 200%. So we've been thinking about, is that an opportunity to keep people in their CCO? Could we create a new eligibility category? The timing of the issue of that really it's really timing. And also you have a reverse problem if you're moving people from the marketplace into that program as well. So just need to be thinking about that as a possibility. We've thought about other federal waivers that might be available to create sort of an option to stay in Medicaid versus moving to the marketplace. And so we've been talking with CMS and are trying to get clarity on all the options. They have said that this basic health plan is an option for us, but I think there's a lot of questions with the legislature and stakeholders around timing of it. There are some flexibility to be able to potentially, keep certain folks, lower income folks on the Oregon Health Plan longer, but that's obviously a state cost to that. So we're working through all those options. I think at the end of the day, the issue that I think we share is that none of us want to go back to a 6% uninsured rate. And I think to Kirsten's point, the federal government's been calling this the unwinding of the public health emergency, which I sort of find offensive as a term of like, I don't think we want to go backwards, right? We need to figure out what forward looks like, but just going backwards to where we were 2 years ago does not seem like the solution either. So I really appreciate the conversation. I think any guidance you all have as we're going into, and the guidance you've already provided today as we're going into legislative conversations this week is really helpful.
Kirsten.
I really like I appreciate you sharing that and offering a little more detail. The idea of being able to take that up to 200% FPL population, keep them with their current carriers, keep them in their CCR with their current doctor, without an extra $80 fee each month sounds so would feel like a win, I think, in terms of addressing one part of a vulnerable population. So I guess I'd like to ask, it sounds like there's maybe some options there. How can we support them? I'm very interested. I would like to ask my colleagues on the board to say, how can we as a group really say that this is important? We know it's a short session and that makes it hard. We know that we are these timelines of we don't know when a public health emergency is going to end, and we'll get 60 days notice before that happens, and then the clock starts. There's a lot of tight timelines here for some big work, and that is intimidating. And but that it's important that we take a leap here and move forward. How do you have firm enough ideas that how can we add some emphasis to this?
I mean, I think what I'm hearing from you all, and would defer to you all on whether you're ready to provide, some type of more specific direction. But I mean, I think what I hear from you all is the importance of being slow and methodical, of not just going backwards, and to finding an option for the churn population that provides an affordable option for them. And I think, and I think in particular prioritizing folks who are at risk of, facing inequities, facing, treatment issues. I think identifying the higher risk folks and making sure that we're really building that into our plans. So if that's what I hear, I think that direction is helpful to us. And I think really, I think an important message for us to take back to the team and the legislature.
John.
Jeremy, you must be thinking about those two words that I know are uncomfortable, but this sounds like something for a special session in 3 or 4 months. And, you're doing fantastic stuff, but figuring it out in this timeline may be very tough. On the other hand, you might be able to really figure this out and have an incredible solution. You have all the, I think, pieces to put something terrific together.
Yeah, thanks, John. I mean, certainly calling special sessions far above my pay grade. But I think, I think we've been trying to figure that out. Honestly, is there a step or a process, whether that's the e-board, is there a process to be able to get some legislative direction, recognize it may not be a fully baked plan, and there's some work that we need to do in a way to have a future kind of, trigger point to be able to have legislature say, yes, go. And that's very hard without a special session or still a legislative session. So we've been trying to think through that. Is that a task force, or coming back to the emergency board, which is a committee of the legislature that meets and has some budget authority in the interim. So yeah, we've been trying to figure out, is there some way, some mechanism to have bring something back to the legislature in the spring, or get some direction, general direction out of the session, and be able to bring something back in the spring. The only challenge in that really is that if the public health emergency isn't extended beyond April, we have to start in May, basically.
Well, Chicky, Jeremy, thank you. It's a very daunting task ahead. I really appreciate the constructive input of the board and the concerns raised, all really important issues. And Jeremy, please let us know how we can support your work and, as I think Kirsten says, not go backwards, but go forwards.
Thank you all.
All right. Last on the agenda is public comment. The Oregon Health Policy Board deeply welcomes and appreciates public comment. It's one of the most powerful ways that we can demonstrate our commitment to profound listening and learning. That means that as we hear public comment, we won't respond directly to what you share or fix and resolve the question here in the moment. But co-chair Arana and I with the OHA staff will reflect on the comment and determine the best course of action. Each presenter is given 2 minutes to share, which often doesn't feel like enough time. We encourage you to provide written testimony to supplement your oral testimony to help us keep on time. You see the timer here. We please ask that you conclude your presentation when the timer is complete. Know that we'll review the any written and oral comments following the meeting, determine the most appropriate next steps, and the board staff will communicate with those who present. We have 3 comments registered today. The first is from Brandon Casey. Is Brandon Casey here? It's we'll come back to Brandon Casey. Let's see, check in with Kevin Fitz. Kevin, are you?
Yeah, hi. For the record, my name is Kevin Fitz. I'm a volunteer with the Oregon Mental Health Consumer Association. I'm here to talk about some concerns I have with OHA and State of Oregon Behavioral Health Advisory Councils. 3 councils I want to say and some questions. Number 1, the Governor's Racial Justice Council. Does it have a single Oregon health plan member on it who's not currently a contractor? Second question, does it have a Black or brown member who's ever been a felon? The third question, what is the average income in the individuals who are attending the Governor's Racial Justice Council? Council number 2, Addictions and Mental Planning Council. Why have we not had more than 4 meetings in over 24 months? Question number 2, how do they fast track the approval of the latest block grant application with us not having enough time to review it, not even having more than 2 meetings to discuss it? Question number 3, does the federal government of mental health services arm SAMHSA know the state of Oregon has been delinquent and having regular meetings under COVID? Council number 3, the Measure 10 Oversight Council. Has this group from the origination been educated and aware of financial conflicts of interest? Question number 2, did one council member unknowingly benefit financially from his position on this council? The third question is, how many of these individuals have ever been customers of the state of Oregon or a beneficiary of public services to treat mental health or addiction services? I have some other comments, but fundamentally, we have 1.4 million people on Medicaid. 200,000 of those approximately are behavioral health consumers. The bait and switch of those living with mental illness who are peer contractors substituting for authentic Oregon health plan consumer voices has gone on so long, I just am blue in the face bringing this up. There are important voices in the peer community to hear, but we also need to make space at the table for Oregon health plan consumers. And I think that we are remiss in even talking about such things. Thank you.
Great. Thank you, Kevin. If you have those questions, please email them to us so we can review those. I really appreciate your comments. We'll next turn to Ayers Lane.
Hello, everyone. This is Aries. I am subscribed, but didn't get a notification for this meeting, and same happened to others. I'm not vaccinated and will never be. I stopped masking months ago. After 2 years, I got COVID for the first time. Everyone I talked to across the world pretty much got COVID in the last 2 months. I never feared COVID, and I was right. It's just a cold. especially for healthy people. So it was kind of fun to get through it and develop immunity. I've been diligently asking questions to OHA about the masking rules decision process. They danced around my questions. And finally, yesterday, we heard back from Rachel Banks. And I learned that she's the one filing the rule and no vote is taken. OHA overstepped their authority and passed the first rule for schools on Friday. And I want you to know, there's at least one lawsuit already filed that calls for an investigation on Pat Allen, whose term expired last year, and also an investigation on Governor Kate Brown, and more are to follow. I'm here to reiterate the ask that you do not pass the statewide permanent indoor masking rule and make it clear that if you keep pushing on us, we will push back and use all the tools available within the framework of the law to fight back. The people of Oregon are standing up. OHA, get out of the way. Your time will be better invested in fostering healthy habits in our communities, addressing vitamin deficiencies, and building up on natural immunities rather than destroying them with vaccines and masks. Stop pushing. Do not pass the indoor masking rule. The people will sue every single person we need to in order to stop this government overreach. I hope you will listen. Thank you.
Thank you for your comment. We will go back to check in with Brandon Casey. Is Brandon Casey here? All right. Well, thank you for your public comment. We appreciate the opportunity to hear public comments to provide a voice from individuals. Also recognize that what is said is our views of individuals and not the views of the Oregon Health Authority. So appreciate your coming and sharing your thoughts with us today. Our next meeting is on March 1st, Tuesday. Since we've heard from the Oregon Health Policy Board's Behavioral Health Committee that their February 1st deadline to the Oregon Legislature directed under House Bill 2086, that the committee's February 1st deliverable is transformative metrics and incentives framework, meaning that it transforms the delivery of care of Oregon's behavioral health system. Because of the short timeline and complex deliverable, they were not ready to submit a framework, but instead will submit a memorandum that provides a review of the committee's work and how the committee will continue its work to achieve their goals. A copy of the memorandum will be shared with the Oregon Health Policy Board members later today. The copy can also be found at the OHA Behavioral Health Committee's website. For our March 1st meeting, we'll hear from the OHA Behavioral Health leadership to learn about the committee's work and their next steps. I want to thank everyone at OHA for informative presentations and thank each board member for a very robust and constructive discussion. I will be away March 1st. The committee will be chaired by Vice Chair Arana, and I wish you all the very best and see you at the retreat in April.